The next portion of our agenda is going to be delivered by Megan Murphy, based at AHI, previously with Adirondack Health, and she is our Director of Community Engagement and is going to talk some about the cultural competency, health literacy aspects of DSRIP, including Bridges Out of Poverty.
Yeah, I will be introducing someone talking about Bridges Out of Poverty. Hi, everybody, today. We're going to shift gears completely now. One of the things we wanted to do is leave you today with something to think about driving home. As we move through the DSRIP process, we have to start thinking about training. You know, we just heard from Kelly about all these trainings, things that are going on. And a lot of times when we think about that, we think about traditional training. But one of the things we're going to be talking with you about is some shared goals, and they're not the traditional metric goals that you're probably thinking of, and I'm glad that we went through a lot of this today. It was good. This was a great overview, and it really helped me also better understand how all these components of DSRIP are fitting together. But there's a lot of components that I think are going to be a little bit unusual about DSRIP, and so one of the things that I thought about when thinking about introducing the person I'm going to introduce today was, what is our shared goal here? I know we have a number of shared goals with DSRIP, but I think what we can all agree on is that we want to see improved outcomes. And I think that if you go out to your neighbors and your people you know at the post office and all that, that everybody would agree that that's something that that's what we want to see from our healthcare system. And I think if you think about it, patients would say that, they want that. I don't think you're going to see a patient say they don't. Your practitioners want that. You know, back when we started the medical home project that Bob's been talking about, that was a big part of bringing medical home to this region, was actually about provider satisfaction, that practitioners weren't really able to care for patients the way that they had really thought they would when they went to medical school. So practitioners are going to say that same thing, improved outcomes. Health insurers, they definitely have an interest in improved outcomes. We all know that. You know, they care about the people that they serve, but they also have a bottom line. And we know that improved outcomes, they've shown that, are going to help health insurers save money. Employers have this shared goal. We've seen plenty of studies done. Johnson & Johnson, lots of large companies have done studies on wellness. They've been doing wellness at work, and what they show is that when their employees are healthier, they get higher productivity, they get less absenteeism, they get better what's called presenteeism. And they're also able to save money on their on disability and health insurance. And I think the community, like I said, when you go out and you go to the post office, you go wherever, everybody agrees that this is what they want to see. When in your community, you know that when you're feeling better, you do more. You maybe do the roadside cleanup, or you go, you help, you volunteer at an organization. You're able to be more present in your community. You may be on your school board, you may be on your planning board. You're able to be out there and be active and be part of it. And so I kind of thought about this shared goals slide. To me was like that idea of, I think I'm stealing it from Stephen Covey, like believe, what is it that, now I'm forgetting what it's called. Start with the end in mind. You know, what are we thinking about here? And so what I'm getting at with talking about this today is that some things that actually influence health outcomes are not actually medical issues. And so the studies have really shown that a number of non-medical conditions are going to influence the outcomes. So one of the things that we've seen a lot of studies on recently is early life experiences, stressors for children, and children under stress have worse health outcomes as they move through life. Educational attainment. We know that educational attainment has been clearly shown to have an impact on outcomes. Income and economic factors are the same. Work, housing, community. One that a lot of people talk about, but we don't focus on as much around here, is race and ethnicity, but I'm sure that you've heard quite a bit about that. The built environment is one that's been coming up more and more in the last few years. The idea that where you live can actually have an impact on how active you can be. Are there sidewalks where you can walk safely? Are there places where your children can ride a bike safely? And those types of things will have an impact on your health outcomes. So we're going to introduce you to a couple of concepts today. This is what I want everybody to be thinking about in the car ride home. We're not going to quiz you at the end. I thought about it, but I'm not going to. We have these great things called Option Finder, and we could actually have you push in your buttons, and we would know how well you guys were listening today. So one of the concepts is called social determinants of health. The other one is health disparities, and there's cultural competency. And so the social determinants of health are, and I'm just going to read it right off the slide. I hate when people do that, but I think it's really crucial that we really think about these definitions. The conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And although I took this definition from the World Health Organization, there are many, many organizations, agencies, government agencies, and healthcare providers looking at this and defining this for their own communities. I've taken the county health rankings model. There are a couple of also different models out there. They give you slightly different percentages. They look like wheels. They look like all sorts of different things. I personally like this one because when you look at the outside line, so you have policies and programs, health factors, and outcomes. And so the policies and programs they can be impacted, they're the larger ideas, that big overarching idea, but what they're going to impact are things like your physical environment. You think, well, how can that happen? And when you think about your planning board in your town, well, your planning board makes decisions that can actually impact the built environment in your community. That impacts decision making, like, are we going to build a sidewalk there? Are we going to ask people to make changes that make it a more walkable community? Are we going to have a comprehensive plan that has that as a goal for our community? And so that can impact the physical environment, which then impacts these pieces on the side, which are those, as we move down, these are the smaller concepts. This is exactly where those policies and programs have an impact. It's the same with the health factors. And so what you see in there is that 30% of our health is impacted by our health behaviors. 20% is actually by clinical care, which is what I think is the important thing in this room for people to think about. 40% is social and economic factors. And then 10% is that physical environment. So what we're trying to get through here is that providers themselves are not going to be able to make all of these goals in DSRIP by themselves, just because you see somebody in an office, that there's a lot of outside influencers that are going to have an impact. Health disparities. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And that one's from the Center for Disease Control. But there's other various but similar definitions out there. And so we want to start getting our DSRIP partners familiar with what are some of our region's health disparities. One of our health disparities that we've identified, and this goes back to that original slide where I talked about race and ethnicity. Many places that's a starting point for them in talking about our health disparities. However, in our area, we have a pretty homogeneous population. You know, it is, some of our counties are actually, in the census data, show that they're 95% white, non-Hispanic. So if you take out that as a health disparity, which we do have to do for our counties, you have to start digging deeper into what is it that's impacting some of these health outcomes for our people. And one of them is education. What we can see from this slide is in the table, you can see that we do a pretty good job of graduating some of our kids from high school. We actually do a good job with that. Where we see that we need more help is actually with higher education, is college associate's degree or higher. As you'll see, the bubble for New York State is quite large. and all of our counties don't quite meet that benchmark of New York State. And so why is this important? Well, studies show that the lower your educational attainment, the worse your health outcomes are. There's a correlation there. And so that's something that providers will struggle with and may not be able to have an impact on by themselves. So the next disparity we want to start introducing you to is the idea of income. In our counties, we do have a higher percentage of people living below the poverty rate. And so you think to yourself, well, I'm a provider. What can I do about that? And you may or may not be able to have a direct impact on that, but that is something to take into account when you're communicating with your patients. Where are they in the economic scale, and how can you approach them in a way that is maybe more culturally competent for someone who's living a different type of lifestyle than you are? And another thing that we want to look at with that, and something that maybe starts to become more actionable for providers as we look at more of a continuum of care model, is that when you start thinking about income and you start looking at and breaking down people's income, you start to realize that there are certain things that this does have a direct impact on. So one of the things that we've started looking at is where are those actionable things going on in our communities that we, in that larger context, can have a potential impact on. And so we started looking at housing. And so recent studies have shown that when people live in unstable housing, they also are unable often to be caring for or doing something about their healthcare concerns. So that's why we're starting to think about some of our less traditional partners, looking at economic development and other people in our communities that are working on these things, such as housing, and saying how can we partner with them to start to really think through how we can more holistically or comprehensively work with people to help them solve some of the other issues going on in their life so that their health concerns can then become more of a priority for them. And so what we see in the slide is that actually in our counties, a number of people are spending a tremendous amount of income on housing. And so what we understand is that maybe this is something we can do in partnership with our economic development agencies and organizations in our communities. And so the last concept I wanted to introduce you to today is cultural competency. So this one's a little bit more complicated. So I thought about it first by thinking about what is culture, what are we talking about? Because again, we're not talking about, in our area, we don't have a lot of people coming to us from other countries, which is a lot of times what people think about with cultural competency. They may speak a different language, and English is their second language, so they're not understanding what I'm trying to communicate to them. And that's true, but it can also be that people within what you see as more traditional people living in your communities may be thinking about things differently culturally. So when I was thinking through this, I thought it's actually can be, it's described as a combination of a body of knowledge, a body of belief, or a body of behavior. And so that's sort of a more encompassing idea of culture than just simply where you're from. The concept of cultural competency has a positive effect on patient care delivery by enabling providers to deliver services that are respectful of and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse patients. And that one's from the National Institutes of Health. And so we, instead, like I said, of looking at a traditional cultural definition, we need to look to our health disparities to help us define for us what are those, where do we need to become more culturally competent with our patients. And I like this graphic because I think that it sort of ignores the whole idea of where you're from or what you're doing, is that if you start with respect and then you communicate, and you really try to understand, you can engage somebody. And we can do that with anyone, not just patients, as my husband probably reminds me every day. So what does this all mean for all of us? And so what it means is that we need to be building these concepts, the social determinants of health, health disparities, and cultural competency into every DSRIP project. There will be lots of training opportunities. Kelly and I have already started talking about this, that are going to cut across all DSRIP projects. So these are not concepts that are going to be attached to one of our projects. These are concepts and constructs that we're going to be trying to work in and training people in across DSRIP. And so today we're going to introduce you to one approach. We have been working, a couple of the different DSRIP projects have been working together on this. And we are going to talk today about bridges out of poverty. So I'm here to introduce Deborah Dam O'Brien, and she has one of the longest titles on the sheet today, which is, I love it, Executive Director, DePaul Housing Management, McCluskey Community Services Corporation, and Catholic Charities Housing. So welcome, Deborah.